Thank you, Michelle, and thank you for the foundation for the opportunity to speak at this really important event. I think looking through the itinerary over the last few days, you guys have learned a ton, and I'm fortunate enough to be the closer here with a little bit of a different topic. My name is Frank Scott. For those that I haven't met, I'm one of the IBD physicians at the University of Colorado. I've been there since about 2015. Before that, I did my training and an IBD fellowship at the University of Pennsylvania, was on faculty there for a little while. I'm involved in the GI fellowship program and our research infrastructure for the division, and more recently took over a leadership position for IBD Chorus for the foundation as well. My topic today will be care pathways for identifying and referring patients with inflammatory bowel disease so that we can expedite them receiving some of the same medications that Dr. Dalal just discussed with y'all to sort of positively impact the long-term course of their disease. These are my disclosures. Our objectives, like I said, are to understand how delays in diagnosis and the treatment of IBD impact disease-related outcomes, to review criteria that are clinically and biochemically based that can assist in identifying new patients with IBD if we're coordinating with our primary care colleagues. And then lastly, for individuals that we're caring for, how can we identify patients who might benefit from referrals to an IBD center, and what are some of the caveats of that approach? Don't need to belabor this here, I'll move through, but we know that the incidence and prevalence of inflammatory bowel disease in the United States continues to slowly increase. It's now approaching approximately 1% of the US population. It tends to occur in the first 3 decades of life. And despite our familiarity with signs and symptoms that might represent inflammatory bowel disease, the presentations overall can still remain quite heterogeneous. This is a survey cohort study out of Oscar, which is like this observational cohort from Providence, Rhode Island, or Brown, where they surveyed individuals who had a diagnosis of Crohn's and asked them what symptoms they were experiencing before their diagnosis. You'll notice that a number of these symptoms we recognize, like urgency and diarrhea, but some patients don't experience those at all. A significant proportion of patients, 20%, just had fatigue or some vague abdominal pain that could easily get written off as irritable bowel syndrome, and a third of patients didn't even have diarrhea at all. Which can lead to sort of the diagnostic conundrum of identifying who might actually have IBD. We also know that some patients can just present with extraintestinal manifestations like dermatologic, ocular, or arthritis-related symptoms. I've cared for more than one patient in my cohort that presented with uveitis as their diagnostic initial symptom without any GI symptoms. And they were fortunate enough to interact with an ophthalmologist that said, maybe you should go and consider a colonoscopy. And that's how we made the diagnosis: 1 Crohn's and 1 UC. We also know that delays in the diagnosis of IBD are associated with adverse events downstream. This was a really important survey study of over 900 individuals with Crohn's disease in Europe. They were Swiss. From 2006 to 2011, they asked them to describe how long they had been symptomatic before they received their diagnosis, and then divided that time length into quartiles, and the shortest being within 3 months they were diagnosed to the longest being greater than 2 years. And you can see in relation to the reference of the short-term diagnosis, a general trend numerically upwards in the risk of complications. Those that waited 2 years, they actually had a 2-fold increased risk of a subsequent stricture and or surgery. Similar data out of Spain, where individuals who were started later on an advanced therapy or steroid-sparing therapy were at much higher risk of subsequently requiring a major abdominal surgery, with the sort of diagnostic or the time to steroid-sparing therapy being quite long. We also know in children that time to advanced therapy in pediatric Crohn's disease is associated with penetrating complications. This is a classic cohort study from Kuga-Gustafson and colleagues that was published in Lancet about 7 or 8 years ago now. They looked at individuals with a new diagnosis of Crohn's and stratified them by whether or not they received an anti-TNF in the first 3 months of diagnosis or later. And those that moved to an anti-TNF later at 3 years were associated with a 70% increased risk of developing a penetrating complication related to their Crohn's disease. So time is clearly of the essence. Lastly, just one more example, not to belabor this point, but this is a study by Jeremy Adler at the University of Michigan and colleagues again in pediatric Crohn's disease, where they looked at perianal disease, and time to steroid-sparing therapy was again associated with an increased risk of developing perianal penetrating complications. So how can we address this? When one thinks about the timeline of an IBD-related diagnosis, there are several phases, and we could sort of break them down into little buckets to help us understand where the sort of pain points are that we might intervene on. Firstly, all the way from the left here, we have the pre-symptomatic pre-diagnostic phase. These individuals are at risk for developing IBD, and we have some markers now, genetic and family history related, that may predict who this population is. But we don't have commercially available fantastic tools just yet to help us identify who's going to go from this group to subsequently becoming symptomatic. After symptomatic symptoms develop, individuals will potentially languish for some extended period of time without a diagnosis, interacting with the medical system, telling their primary care team, hey, I'm here, something isn't right, but not getting the workup they need to make the confirmatory diagnosis of inflammatory bowel disease. Even when individuals are diagnosed, we'll review some data here, they may not make it to this right box here of being appropriately triaged and treated for some period of time, and that delay is associated with adverse outcomes, as we saw with the pediatric data. So one could envision trying to intervene at any one of these steps. As I mentioned, biomarkers or genetic screens could be available. There's a lot of fantastic work going out of the Mount Sinai group right now related to this, and in Europe as well. Once individuals become symptomatic, we could better interact with our primary care colleagues and inform them about sort of clinical factors and or laboratory data that might trigger an expedited referral to GI. And then lastly, once an individual has a diagnosis, we can do a better job on the GI side of identifying those individuals who are at highest risk and may benefit from being referred to an IBD Center of Excellence, either to work with them in collaboration or to assume care. Fortunately, there are some tools now that are available to sort of triage and target those last two boxes, managing the individuals with symptoms who are not yet diagnosed but are high risk for a diagnosis, and managing those with a diagnosis and identifying who's at sort of higher risk for a poor outcome. And so we'll review a few of those here over the course of the rest of this talk. The Red Flags Index was one of the first of these clinical indices to help use symptomatic factors to more rapidly identify patients with Crohn's. This was conducted via the IOIBD, which is an international sort of panel of experts that you have to be invited to be a part of. They convened 12 experts and performed a very thorough systematic review and identified 13 studies of predictors, symptom-based predictors of having a diagnosis of Crohn's disease. And then they compiled a 21-item questionnaire. And many of the things that they derive from their literature search are not surprising for us as APPs and physicians who manage inflammatory bowel disease. They include signs of systemic illness like weight loss and fevers, penetrating complications such as fistula or strictures, extraintestinal manifestations, urgency, failure to thrive, tobacco status, and family history of IBD or other autoimmune diseases. They then took these and, using a retrospective cohort of individuals who were diagnosed versus those who were not diagnosed with Crohn's disease, built a regression model to build a little scoring system. And these were the coefficients here. What this means is that these are numbers. So for each of these point estimates or each of these clinical symptoms here, you would get a score. And so, for instance, if you had a perianal disease and you had nocturnal diarrhea, your score would be 8, whereas you just had a mild fever, you would only get a 2. And they identified a cutoff, and that cutoff was 8. If you had a score of 8 or more from this scoring system, the model strongly predicted you having a future diagnosis of Crohn's disease. So this is a list of sort of potential clinical criteria that you could share with your primary care teams locally, saying, hey, my time to intervene on a patient is ticking from the minute they become symptomatic. And we know the longer that we wait, the higher risk of complications the patient will have. If you see patients with these symptoms, please consider referring them to us. Um, you can see here, this is an ROC curve for those that aren't familiar with that this model had a very, very high sensitivity and specificity. And from a statistical standpoint, whenever you see this kind of curve, it does make you feel like there might be something called overfitting present, which means that this may not bear out in validation. And sure enough, when they then went and applied these criteria to another prospective cohort across 3 centers in Europe, the sensitivity and specificity did drop off significantly. I just want you to focus on these dark histogram bars. You can see here that the sensitivity dropped to 50%, and specificity dropped to 60% for that cutoff of 8. But importantly, the negative predictive value, or the absence of a score of 8, strongly predicted that you didn't have IBD. And then they did another cool thing, which is they added fecal calprotectin. And we know that fecal calprotectin naturally has a very high negative predictive value, meaning that if somebody has symptoms that you're concerned about being IBD, but they have a negative calpro, the probability that they actually have IBD is exceedingly low. And you can see that the sensitivity rose to 100% with the clinical symptoms of 8 and a calpro, and the negative predictive value, if they didn't have a score of 8 and they had a normal calprotectin, that it was 100% in this cohort. But, one validation study, but an interesting proof of concept. IBD Refer took the work of the RFI and took it another level here. They took the criteria, and instead of just having a blanket list with scores, they tried to simplify it a little bit, divided the criteria, their own criteria, which are modestly tweaked, into a major bucket where you only needed 1, and a minor bucket or secondary bucket where you needed 2, and added in biochemical markers and laboratory parameters like fecal calprotectin, ASCA, ANCA, which is not part of my routine practice, or elevated systemic inflammatory markers like CRP or ESR. And and you see here on the left side with these histograms, had sensitivity and specificity with laboratory parameters for major or 2 minor criteria of greater than 95%. So doing a really good job of identifying individuals who potentially could have inflammatory bowel disease for referral. So these are, like I said, 2 systems that could be used to identify and triage individuals who are at risk for developing IBD. But what about our patients who have IBD already? Unfortunately, there is emerging literature that we are not using our advanced therapies appropriately. And that's really, and we'll spend the rest of the time sort of talking about this part, which is more where we come in. This is unfortunate. This is the timeline of the expanding armamentarium of inflammatory bowel disease. I just want to highlight, to age myself, that I finished my IBD fellowship right around this purple ball right here. We had 2 anti-TNFs, the immunomodulators, and steroids at that point. And I've gotten the opportunity to witness sort of the explosion of existing therapies, including some, as you just learned about, with favorable safety profiles, different modes of delivery, including sub-Q, oral, and IV formulations, depending on patient preferences, et cetera. And so the sort of the landscape of inflammatory bowel disease has dramatically changed. And we've got some really compelling data using historical cohorts that show that just having IBD now in comparison to having IBD 20 years ago is associated with a 20 to 30% reduction of a surgical risk over time. So it's really, really fascinating stuff. But we're not getting to everyone, and that's what I want to highlight over the next 2 slides. This was a really important study out of the VA by Akbar Walji, who's at Michigan, and his colleagues. They looked across the national VA and identified individuals with a diagnosis of inflammatory bowel disease who were either receiving continuous corticosteroids in the top half of this table or intermittent corticosteroids. These are the patients that we should be identifying as needing advanced therapies to prevent those corticosteroid exposures, which we know are associated with an increased risk of infection, bone-related complications, and even blood clots. Unfortunately, even when individuals saw a gastroenterologist And granted, the VA may have some resource limitations at times that preclude that. But even those that interacted with GI and had continuous or intermittent corticosteroid use, a third of those did not get moved on to advanced therapy during follow-up time. And the situation was even bleaker for those that did not get the chance to see a GI doc. Two-thirds did not get moved on to an appropriate advanced therapy. Now, you may say, okay, this is related to the VA or something unique there. There's a lot of barriers that this isn't unpacking. And I agree with those sentiments that there's a lot of different factors that could be interacting here with the patients moving on to an advanced therapy. But this work has now been repeated outside of the VA as well. This is a really fascinating paper that was published by Corey Siegel last year in Crohn's and Colitis 360. They looked at a cohort of several thousand individuals with Crohn's and UC in MarketScan. For those that aren't familiar with MarketScan, this is a large data set that sort of collects payer data from private insurance companies and collates it, and then you can ask research questions of this data set. They had, like I said, thousands of UC and Crohn's patients. They had average follow-up time of about 2.5 years. These were incident diagnoses, which means they were new. And then they saw what percentage of patients made it to an advanced therapy over time. And some things to highlight: a significant proportion here in this blue bar demonstrate that people were getting steroids, and subsequent therapies continued to be steroids as opposed to or non-steroid, non-advanced therapies to a much lesser extent. Despite them interacting with the healthcare system, getting these prescriptions, only 6% of patients with ulcerative colitis during that median follow-up time got moved on to an advanced therapy, and only 14% of patients with Crohn's disease did. This does not match with our understanding of the epidemiology of patients with inflammatory bowel disease in the United States in terms of percentages that have moderate and severe disease. So we are clearly undertreating patients with inflammatory bowel disease, and those patients are the ones that are going to be highest risk for a future surgical penetrating complication, hospitalization, or continued corticosteroid exposure. So where is the gap here? There are, like I said, potentially numerous factors. Is it provider comfort? Programs such as this can help address that. Informational and educational programs at national conferences can help our physicians and advanced practice providers be more comfortable with the use of these medications in a timely manner. But is there also some aspect of it that's patient comfort with receiving them? We don't know if the issue is that patients just are too concerned about the adverse event profiles. Perhaps they need better educational tools to help understand that there is a stratification of potential safety profiles for each of these therapies. There are different modes of delivery. If there are financial concerns, there are support programs, and we can do a better job of informing patients in that regard as well. Is the major issue potentially support to navigate the drug initiation process? This has been a research interest of mine for some time now, and we know that prior authorizations, for example, significantly delay the start of a new therapy. And those delays do, over the next 6 months, increase the risk of adverse events like healthcare utilization and or surgery. And lastly, are we just not appropriately identifying those who may benefit most from getting to an advanced therapy? Is there a misconception that it's still okay to write that third script of prednisone in somebody with a new diagnosis, that they'll eventually come around, as opposed to just getting the party started and getting them on a biologic or small molecule? And so this area here, identifying those who may benefit most from referral, is an area that we've recently tried to target. First off, who do we refer them to, though? And I think the IBD Center model, while not completely well codified at this point, does have some unique advantages to address all of those concerns on the prior slide. First off, with IBD center expertise and the physician or provider side, we know the risks of medications. We can do the appropriate counseling. We can also often have integrated mental health services to help patients who may have concomitant psychiatric comorbidities. We know that 30 to 40% of IBD patients have a concurrent diagnosis of depression or anxiety, and that may interfere with their receiving treatment. We often have integrated social work services that allow us to help navigate the financial aspects of starting a new drug, of ensuring that they have appropriate financial and family and local support to get to the infusion center, that they know about patient assistance programs, nutrition assistance to ensure that our patients are getting enough calories when they're most sick, and or if they want to explore dietary options, that they have a literature-based and evidence-based approach to doing so. We can maximize general healthcare maintenance through the use of vaccination programs that are not only we're aware of, but we can deliver in the clinic. We can give you your pneumococcus vaccine on the spot. And then lastly, we may have access to telehealth capabilities that some smaller community centers may not. Colorado is a huge state, as an example. Patients can drive 6-7 hours still from Colorado to see me at Anschutz, and I still take care of patients in Wyoming. And fortunately, because of interstate interactions, those patients can do a virtual visit with me, which is a great resource for them. And so while these are sort of the aspects that we regularly sort of view as being part of an IBD center, and they can each sort of interact with some of those issues on the prior slide, I just want to highlight that sort of like this formal designation doesn't yet exist. It's still like in the domain of like, an IBD center when you see what components they have, but there is like no formal list of IBD expertise. We did try to put together some criteria that, using the similar structures that we saw before from Red Flags Index and IBD Refer, that could help us identify the patients who might be most interested in getting referred to us either for a one-time visit or for continuous care. To do this, we convened a panel of 11 providers. 5 of us were IBD experts. 2 were general GI, 2 were primary care, 2 were patient representatives, and then we conducted a scoping literature review to identify simple clinical or biochemical factors that might predict poor outcome in IBD, that might say to the local provider in a GI practice to say, hey, this person is high risk. I'm comfortable doing X, Y, and Z, but maybe I'll just get the opinion one time from an IBDologist as well to ensure that we're all on the same page. And for those that want to see this manuscript, I think this QR code works. I tried it before I brought my slides up. I'm not a QR code expert, but that should link you to the paper from IBDJ from 2023. We used a modified UCLA methods or RAND methods to rank all of the criteria that we identified. And then, borrowing from IBD Refer to simplify things, we scored them based on expert panel opinion scores, and then stratified them into a major criteria bucket and a minor criteria bucket, with one criterion indicating that you should just consider referral then, especially if you're not comfortable, and 2 or more of the minor indicating that you should do the same. And these are our major and minor criteria here. And I know this is small text, but I'll just walk through a couple of these for you quickly. Persistent bleeding or anemia, signs of systemic illness, penetrating complications or history of surgery, weight loss, malnutrition, elevated inflammatory markers were all felt to be major criteria. If you're treating a patient and they still are exhibiting these symptoms or signs despite what you're doing, then it's time to move on and potentially to consider referral if you have access to an IBD center nearby, just to weigh in. And then minor criteria included concurrent opioid use, continued GI symptoms like diarrhea, nausea, or vomiting, abdominal pain, some symptoms that may suggest comorbidities like elevated liver enzymes that may influence care, or family history of IBD, or joint pain or arthritis. Now, this seems pretty simple to follow, but it's important to emphasize again that this is all expert opinion based. It's all based on literature review and a scoping systematic review of what is out there in terms of symptoms that predict a poor outcome in IBD. And validation has not yet been conducted for this pathway, although I will say I have a very eager team of medicine residents that are hoping to become GI fellows, currently working on this. They're examining several hundred individuals that were referred to our IBD center to see when they would have met these criteria and understand how long it took for them to get to us to begin to validate this process. And then lastly, I've mentioned this before, but I want to emphasize it again. The definition of an IBD center of excellence, or even what an IBD expert is still nebulous. There's no sort of formal designation. I think that is a potential step forward for us as a field to figure out how we're going to do that. But there's obviously a lot of sort of political back and forth about the potential ramifications of doing so. So, in summary, delays in both the diagnosis and appropriate advanced therapy initiation are associated with worse outcomes in inflammatory bowel disease. We fortunately have several now validated clinical instruments that can help us identify those who are at risk of developing IBD so we can have our primary care teams expedite referral to us to evaluate for and rule in or rule that out. And more recently, the attention has been also shifted from identifying new or future diagnoses to also assisting those who have current diagnosis so that we can get them to appropriate advanced therapies faster and reduce potential long-term healthcare utilization and implications of having active continued IBD. But the refer to whom we refer requires further validation and standardization. So thank you for your time, and I look forward to chatting with you about any questions you may have.